ahead and get started on our second abstract session here. I'm joined with Dr. Roy right now, so we will go ahead and get started with our first abstract presentation. The first presentation will be given by Dr. Shakti Dahiya from the University of Pittsburgh. This is authored by a young investigator entitled Acinar Regeneration Does Not Involve Acinar Ductal Metaplasia. And as Dr. Dahiya comes up, I just want to inform we're going to try to reserve the questions for the end. We'll go through all the abstracts and then address questions at the end.
Okay. Okay, that's fine. Thank you so much. So a very good afternoon, one and all. I introduce myself as Shakti Dahiya, working as a postdoctoral associate in Dr. Esni's lab in University of Pittsburgh. I deeply thank American Pancreatic Association for giving us the opportunity to talk on the topic entitled Acinar Regeneration Does Not Involve Acinar Ductal Metaplasia. So it is well known that acinar cells, they are very much heterogeneous in nature in terms of plasticity, proliferation, and regeneration, and only a minor subset of acinar population retain the proliferation potential. So there was a study by Volney et al. In 2016. What they did that they marked a proliferative acinar population by marker STMN1, and after injury, the expression of this STMN marker goes significantly higher. So we are more interested in this proliferating population. So we design our study by keeping this thing in our mind. And to execute the design study, we contacted our collaborator in the Austria and they provided us the STMN-CRE mice, and we made a cross with the reporter line and generated a line and treated the mice with tamoxifen for 3 days and harvested the pancreas at day 3 and 2 months. So at day 3, what we found that there is a very few STMN positive cell, but at 2 months, there is a significant increase in the STMN population. And here the graph showing that at baseline, the number of the tomatopositive cell is less than 1%, but at 2 months, it goes up to around 5%. So to study the effect of these STMN population after injury, what we did that after giving the tamoxifen treatment, we induced the cerulin injury and harvested the pancreas at day 3 and day 7. And we took day 3 post-tamoxifen as a baseline. And what we found that at day 3 post-cerulin, there is an expansion of tomatopositive cell, and it goes significantly higher at day 7. And the data showing here that at day 3, the number of tomatopositive cell is around 20%, but at day 7, it goes up to 50%. And that these tomatopositive cells are proliferating or not, we did Ki-67 staining, and we found that, yes, these tomatopositive cells are proliferating. So in this slide, it is basically showing that the expansion of these tomatopositive cells is correlated with injury. And as we can see in the middle lobe, there is a very high number of STMN expressing cell showing the high percentage of injury, and the lobe next to it showing less number of STMN showing less injury. So this is the limitation of this cerulin injury model, that it is not uniform, it is very local. Apart from that, what we found, apart from the expansion of the tomatopositive cell, what we found that there is another new onset of STMN population, and its number got significantly higher from day 3 to day 7. And the graph showing here, it's showing that at day 3, the number of total tomatopositive and STMN positive population is around 2.5%, but at day 7, it goes up to 10%. So according to the current dogma of ADM, it's like after injury, the acinar cells, they dedifferentiate into the ADMs, and upon recovery, they again redifferentiate into the acinar cell. So according to the published data, all the tomato positives, the ADM should be positive for the tomato positive cells. But surprisingly, we did not found that, and as we can show here, that the ADMs are negative for tomato. And there is a new onset of STM population here. So now we are having two different kind of population. One is that is already expressing the tomato positive cell, and the one is the new onset of the STM population. So to find out the original STM population, what we did, that we generated the STM DTR mice, and we ablated the original STM population and harvested the pancreas at day 3 and day 14. So in the wild type, what we observed, that the percentage regenerated area is very much higher. But in STM and DTR mice, the percentage regenerated area is very much low. And in the graph, it is showing that in wild type, it is around 95%. And in day 14, it was around 40%. So this slide is basically showing that in the STM and DTR, it is also following the same pattern, that this cerulin injury model is not uniform. And here, what we can show here, that one of the pancreatic lobe is completely gone. It's not regenerated, and lobe next to it, it still looks pretty normal. So I'll conclude my slide with 3 major findings: that expansion of STM positive cell is correlated with injury, regeneration following cerulin-induced acinar injury relies on proliferation of STM facultative cell, and acinar regeneration does not rely on ADM formation. In the end, I would like to acknowledge my team, my lab mate Jorge, University of Pittsburgh, UPMC Children's Hospital, our collaborator in Austria, NIH, JDRF, for providing us the infrastructure and the funding for the execution of the study. Thank you so much. Okay, thank you so much.
So again, we will reserve questions for the end in the interest of time. And now we want to again thank Dr. Dahian. Now we're going to move to our second abstract, who is presented by Dr. Soren Olesen from Aalborg University Hospital. The abstract is titled, "A large proportion of chronic pancreatitis patients have no prior history of acute pancreatitis, a Danish nationwide population-based study." Dr. Olesen.
Thank you very much. Good afternoon, everyone. I'd like to thank the organizers for selecting our abstract for a podium presentation here today. I'm going to talk about epidemiology from a study we have done in Denmark, where we have some extensive national Danish health registries. So the background of this study is probably known to most of you. We have a conceptual model of chronic pancreatitis as proposed by Dr. Whitcomb some years ago, that basically tells us that chronic pancreatitis is a disease that develops in patients with certain risk factors through immune cell activation via recurrent acute pancreatitis. This is a very well-established model that has been widely sort of adapted by the field, but it also has some limitations. For example, it has been shown by a number of studies that about 30 to 50% of the patients seems to bypass the acute inflammatory pathways towards chronic pancreatitis. And also, importantly, at the present, we don't have any population-based data where we have looked at a risk population and followed them onwards towards chronic pancreatitis. So in an attempt to try to bridge this gap of knowledge, we used the Danish National Health Registries and tried to develop an epidemiological model of the conceptual model of chronic pancreatitis. And it soon realized that it was actually a little bit more complex than we first anticipated. Because if we consider this from an epidemiological perspective, we can see that this model actually comprises of 6 states. It has a stage where the patient has not been a patient yet. It's a risk state, the no pancreatic disease state. Then we have 4 pancreatic disease states: acute pancreatitis, recurrent acute pancreatitis, chronic pancreatitis, and eventual PDAC, pancreatic cancer. And then importantly, we also need to think about death, because death is a competing risk in this situation. You cannot have chronic pancreatitis if you die. That's pretty obvious. So this is very complex. So it gives us 4 trajectories or 14 disease pathways. For example, 3 trajectories or pathways to chronic pancreatitis and 4 to pancreatic cancer. The method is fairly straightforward. It's a historic cohort study based on a nationwide population-based registries. The study period was from 2000 to 2018. We included all Danish citizens above 18 years as the study base, and after exclusion of prevalent cases of acute chronic pancreatitis as well as pancreatic cancer, the final study cohort comprised of a little less than 4.7 million people. They were followed up for the outcome of chronic pancreatitis and pancreatic cancer based on ICD-10 codes, and importantly, we have fairly good validity of these codes in the national Danish health registries. We also constructed some covariates to try to look into demographic, socioeconomic factors, as well as surrogate markers of smoking and alcohol exposure. And finally, with this multi-state statistical modeling. The output of the model is basically the 14 different transitions. And due to the time constraints today, I'll only show you data on the transitions towards chronic pancreatitis. So during the follow-up period, we identified nearly 9,000 cases of new diagnosed chronic pancreatitis or incident chronic pancreatitis. And the idea was then to map out the pathways towards chronic pancreatitis. So we started off with not having pancreatic disease from the beginning, and we wanted to see the pathways down to chronic pancreatitis. So the first pathway we looked at was the pathways involving a single episode of acute pancreatitis. And through these pathways, a little more than 20% went. The second pathways was the pathways involving recurrent acute pancreatitis. And you can see it's about 14% of the patients. And surprisingly, we could actually see that the by far most important pathways was actually a pathway including patients at risk, but without pancreatic overt clinical pancreatitis. So that was 64%. So the majority of patients actually went through to chronic pancreatitis without any previous diagnosed codes of acute pancreatitis. We could also look at it from another perspective, looking at incident rates. The overall incidence rate of chronic pancreatitis was 0.11 for the total population. But if we broke that incidence rates into the 3 trajectories or disease pathways, we could see that it was a little bit lower for the no pancreatic disease towards chronic, that's expected. But you could also see that if we look at acute or recurrent acute, it accelerates dramatically. So this is actually sort of supporting the SAFE hypothesis. We also looked at different risk factors for disease progression, and here I'll only show you the trajectory for acute to chronic pancreatitis, as this is the most important from a clinical perspective and from the perspective of secondary prevention. And as you can see, we identified the usual suspects, sort of to say it, for chronic pancreatitis risk: male sex, lower educational level, lower economic income, smoking exposure, alcohol exposure, and so forth. Finally, on this model, we can also build something we call state occupation probability plots. And that's an interesting thing because you can actually show that to the patient and explain what is the likelihood of disease progression in the years to come. These state occupation probability plots are again designed for patients with incident acute pancreatitis events. And we have stratified them based on gender and on age groups, meaning below 40, 40 to 60, and above 60. And you can see when we look at the gender effect that there are more or higher risk in patients of male sex as compared to females for progression to chronic pancreatitis. But you can also see that the risk of progression is most obvious in the younger disease subgroups, while if you look at people over 60, you can see that the competing risk of death becomes very clear. And I think that's something we have not really looked a lot at in previous studies. So to wrap it all up, we can see that more than 50% of chronic pancreatitis patients have no prior hospital admissions or at least diagnosed codes for hospital admissions for acute pancreatitis in a population-based setting. On the other hand, we can see that patients with prior history of either acute single attack or recurrent attacks have a markedly increased risk of chronic pancreatitis compared to population-based controls. So this is supporting the safe hypothesis. And finally, we confirm male sex, lower socioeconomic status, smoking and excessive alcohol consumption as independent risk factors for chronic pancreatitis. We have also modeled the same patterns for pancreatic cancer, but I have not time to show you these data today, but they will eventually go into a paper. Thanks a lot for your attention.
Thank you for that, Dr. Olsen. We will now again move to our next abstract. This will be presented by Amanda Ruelas from Vanderbilt University Medical Center. The abstract is titled "Tuft Cells Inhibit Pancreatic Injury Through IL-25 Synthesis and Secretion."
Hi, everyone. My name is Amanda. I am a second-year graduate student in Kathy Del Giorno's lab at Vanderbilt University. And today I'm going to be presenting how tuft cells inhibit pancreatic injury through IL-25 synthesis and secretion. So chronic pancreatitis is a major health concern and is characterized by this consistent unresolved inflammation that can lead to irreversible damage and to complications like pancreatic cancer. And chronic pancreatitis is characterized by this process called acinar to ductal metaplasia. Acinar to ductal metaplasia is an early response mechanism to injury where pancreatic acinar cells undergo transdifferentiation into ductal cells. And we recently published a paper where we identified different cell types and states that arise from acinar cells during chronic pancreatitis using lineage tracing. We crossed our pancreas-specific Cre to a YFP flox reporter mouse model, labeling all acinar cell origins with YFP. So we treated these mice for 4 weeks with cereulin, a drug that induces pancreatitis, back sorted for YFP positive cells, and conducted single cell RNA sequencing. And we found that acinar cells not only give rise to ductal cells during pancreatitis, but they also give rise to other cell types like tuft cells. And here are some tuft cell markers that we use to verify their identity, like PAU2F3 and GNAT3. And tuft cells are these chemosensory cells that are normally found in the respiratory and digestive tracts. They are identified by their structure where they have these deep actin rootlets and short blunt microvilli. And in the intestine, they are known to participate in helminth or parasitic worm clearance. PAU2F3 is also known as the transcription factor that regulates formation of tuft cells. And so to get an idea of what these tuft cells are doing in the pancreas, we crossed our pancreas-specific Cre to a PAU2F3 flox mouse model, ablating tuft cells in the pancreas. We conducted immunostaining using PAU2F3 and VAV1, a tuft cell marker, to verify that these mice do not develop tuft cells. And similar to your left, we have a PAU2F3 quantification of immunostaining showing lack of tuft cell or PAU2F3 expression. We also looked at pancreas weight to body weight ratios, which are a measurement of necrosis. And we saw that mice lacking tuft cells have significantly more pancreatic damage, indicating that they may play a protective role during chronic pancreatitis. We have also shown that tuft cells are associated with human chronic pancreatitis. In these SCOI-F samples, we see in yellow phosphoglutamate, which is a tuft cell marker present in the metaplastic ducts of human chronic pancreatitis human tissue samples. There's also RNA sequencing data that shows similar trends to mouse models, where in the normal pancreas, there's little to no tuft cell formation, but during pancreatitis, we see tuft cells populate. And here are some of the tuft cell markers that were enriched in the human chronic pancreatitis samples. And so to get an idea of how these tuft cells are mitigating injury, we wanted to know if tuft cells alter the immune environment during chronic pancreatitis. So we treated control and tuft cell knockout mice with cerulean for 4 weeks and conducted mass cytometry on areas of injury for a number of different immune cell markers. And we definitely saw some differences. And some of these were a decrease in T helper cells, an increase in T regulatory cells, cytotoxic T cells, and activated fibroblasts. And these changes are more associated with a pro-inflammatory immune environment, indicating that tough cells might promote an anti-inflammatory environment during chronic pancreatitis. And so we looked at our single-cell RNA sequencing data and saw that in the injured pancreas, tough cells are the only cell type to express this cytokine IL-25. And IL-25 is a context-specific cytokine, and in cancer, it is known to be anti-inflammatory. So we conducted qPCR on our pancreatitis tough cells to confirm that they do express IL-25. And we also got our hands on this IL-25 reporter mouse model, induced injury with cerulean and stained for pherloidin, which marks the actin rootlets of tough cells, and verified that yes, these pancreatitis tough cells do express IL-25. And so we're really interested in understanding how this tough cell derived IL-25 is mitigating injury. So we crossed our pancreas-specific Cree to a IL-25 Flox allele mouse model that is also a reporter for IL-25 expression with RFP. We conducted immunohistochemistry to verify that these IL-25 knockout mice do not express IL-25. And we've also done other immune staining to verify that these IL-25 knockout mice still express still develop tough cells. We also did H&E staining, and similar to the tough cell knockout mice, the IL-25 knockout mice have much more pancreatic injury. And with trichrome staining, we saw that in the injured, or that there was a lot of edema or extra fluid, which is very indicative of an inflammation response. And so right now, the working hypothesis is that during injury, Ashner cells transdifferentiate into tough cells, which then secrete the cytokine IL-25. And then IL-25 signals to other immune cells that secrete other cytokines like IL-13 or IL-33 to promote this anti-inflammatory immune environment. And so right now, for future directions, I want to uncover the mechanism of how this tough cell-derived IL-25 is mitigating injury. And specifically, I want to identify if there is a relationship between tough cells and the pancreatic stroma. I also want to characterize the immune landscape without tough cells or IL-25 to investigate the immune cell infiltration differences that may be contributing to this anti-inflammatory immune response. And understanding how tough cells mitigate injury during chronic pancreatitis will give us a lot of information of how the pancreas heals itself and how we can harness that information to design better diagnostics and therapeutics for patients who have chronic pancreatitis. And with that, I thank you all for listening, and a big thanks to my lab and my funding sources. Thank you.
Thank you, Amanda. We will now invite our next speaker, Dr. Mohammed Othman from AbbVie. He will be discussing the development of a clinical screening tool for exocrine pancreatic insufficiency in patients with chronic pancreatitis.
Thank you so much. Mohammed Othman from Baylor College of Medicine, presenting this research on behalf of my authors, Dr. Kaur, Dr. Singh, Dr. Fosmar, Dr. Lara, Dr. Zhang Yadav, and Dr. Park. And this was a collaborative work between all these institutions. So what is the problem with API? We really do not have an easy test to diagnose this patient. So a lot of us who are doing endoscopic ultrasound, and we're seeing this finding of chronic pancreatitis and Rosman criteria, or even imaging study showing chronic pancreatitis. What is next? Are this patient having API or not? We have many tests, but most of them are difficult. A lot of times the patient are not doing them. What was our objective? Was to develop a clinical screening tool, something that our clinician can really easily use in their clinic and predict whether the patient has API or not. So how did we start? We decided to collect data from six centers, and these centers are pancreatitis centers. They have substantial experience in diagnosis and treatment of chronic pancreatitis, and which shows two cohorts of patients. One was chronic pancreatitis and API, and the other was chronic pancreatitis without API. Total number of patients was 274 patients. As we can see here, the inclusion criteria for API was based on not only clinical testing and that the patient was receiving PERT, but also, or pancreatic enzyme replacement survey, but also fecal elastase less than 200, the coefficients of fat absorption, or stool fat excretion more than 10, and obviously some centers too, they have the secretin stimulation pancreatic function test, and value here was less than 60 milliequivalent per peak. So any of these method was diagnosis of PERT and clinical diagnosis by expert that this patient really have API. On the other hand, this other patient did not have API, but also had chronic pancreatitis. And basically the criteria would be the opposite of what we talked about right now. But we did something different. We decided to cast a wide net. We decided to look for many, many factors that can lead to chronic pancreatitis. A lot of variables. These variables may be mentioned in literature or some key opinion leader and expert thinking about them. And we came up with 64 potential predictive value. For the patient that were included in the trial, they had to have enough data to be included in the trial. So if they had less than 80% of 43 main, what we call them primary variables, if you don't have less than 80%, they're not included in the study. Why that? We wanted to have a robust model to predict API. So most of the included patient had all the data we want. And we started with that number of that full set of 274 patients. What was our endpoint? Our endpoint is the API status and the API misclassification rate. How good is this model? How can you classify API versus not? So it is very practical endpoint. All right, I don't want to bore you with the statistical part here, which Dr. Kaur did a lot of good job in doing it, and we had a lot of discussion about it. But basically, we tried many models to do that. One of them called the CART method, and it's basically a tree with yes and no. And that CART method will generate certain variable that are very important, that if you answer them by yes or no, it will give you a results. There are also other methods called logistic regression with lasso, SMV, support vector machine, random forest. We tried all these methods and we put all the variable there, and you have to train your model. And you do that by doing cross-validation, and we did 10-fold cross-validation, and we came up with the results I'm show right now. So these are our patient, 160 with API, 114 without API. You can see the smoker status here and the alcohol status. And these are our 10 models. The most important variable was the smoking, pancreatic atrophy, steatorrhea is another one, alcohol use, serum hemoglobin level, serum vitamin D level, pancreatic duct abnormality, serum albumin, parenchymal classification, and use of opiate. I would like to say that this is not all the variables. There are other variables that they could be important, but for the CART model that has only 10 variables, we discovered that this 10 variables are the one that will give you the most accurate results. So we can see here, if you look at that decision tree, then big arm, you start with a steatorrhea, that the patient has a steatorrhea, yes or no, and you answer this question, it will take you to one of the trees. And the next question will be, does the patient smoke this amount of cigarette? And if you say yes, you have API. So you only had to answer 2 questions, you get to the diagnosis. Imagine it as an app on your iPhone or any phone you have, and you say no, take you to the other arm, and then the other arm will be pancreatic atrophy. And pancreatic atrophy, yes or no, and you will go through this algorithm. So for us, for newer generation, they like this app and chicken and touch. So all what they're gonna do, touch yes or no, and you'll get a predictive model at the end. So how did this? Well, you can see here, that's what we call the confusion matrix for the trained CART model. And we can see here the sensitivity is 0.88, the specificity 0.78. It's much better model to rule in API than ruling it out. And that's a comparison between the CART model with all the other models. So let's talk a little bit here about the other models. They have many variables, some of them up to 47 variables. Clinically, it's not easy to use them. When we try to look at the training error, initially you'll find that other models did better than CART. But then we did what we call five-fold cross-validation. What we mean by that is that when you have a training set, you cannot just trust it by itself to test the model. You have to do cross-validation by making random samples 5 times and so on. And as you can see here, the miss rate, once we had the five-fold cross-validation, was almost similar between all the models. So why CART models and not the other models? Easy to use. It is only 10 variable, yes or no. And also, it's not required by FDA to be a device, so you need to do more validation study. So in conclusion, classification regression tree, which we call it CART method, provided the best option for clinical screening 2 among 5 evaluated predictive model. The chosen CART model that I just showed you right now had 10 predictors. 2 to 5 of them were the main one, as we can see here: pancreatic atrophy, steatorrhea, and smoking, with the 3 arms that you can go through, and then you can have prediction. I feel if we use this in clinical use, our trainee and our fellows will just be able to quickly say this patient has pancreatic atrophy and smoking, or steatorrhea smoking when they have API right away. So it allows us to identify this patient early on. Also, CART demonstrated a good prediction performance for API, specifically the sensitivity was much better, and further analysis to optimize the API screening tool for use in clinical practice are currently ongoing. Thank you so much.
Thank you, everyone. So what I'm going to do is we're going to ask our first 4 speakers to come up. We'll do about 5 minutes of questions, but more before moving to the last 3 abstracts. So if the first 4 speakers can come up and sit next to us, and we'll open up the floor for questions. Please go ahead.
Phil Hart from Ohio State. Question for Dr. Othman. Thanks for the presentation, very interesting. I'm curious about the selection criteria for the cases with EPI. I think for many of us in the room, having a fecal elastase level less than 200, we would not equate that with diagnosis of EPI. Did you or were you able to do any subgroup analysis to potentially use a less controversial and more consensus-based definition for EPI? I mean, it's nice to have a decision tree. However, if it only, if the reference standard is something that is, not agreed upon, it's problematic. That's first part. Second part is, how does the model perform if you exclude the patients with overt steatorrhea? I think for the clinicians in the room, if a patient has overt steatorrhea, we don't need a decision tree, or some would argue even stool tests to
Yes.
move forward with therapy.
Yeah, both are great questions. So I would say your model is as good as the included sample. And that's why fecal elastase was one of the criteria, but we also had pancreatic function test and 72-hour stool test. But so most important, that was a retrospective chart review of patient on centers that highly specialized, that the pancreatitis experts said that this patient has EPI. So it's not only that the test was additional thing, but the main value that they have to be in this high center was experts who decided that is EPI. In regard to the other question, so what if the patient doesn't have a steatorrhea? In the model, we found that other values like vitamin D, pancreatic atrophy, and also serum hemoglobin less than 15 was also a predictive model. So yes, the good thing about CART model is that even if you don't have a steatorrhea, you can just move to the other part and say, so what about vitamin D and other values? So yes, you can use it without, even in absence of steatorrhea.
Great. Thank you. Fascinating talks, Suhail Hussain. I was really fascinated by the finding that about 65% of your Danish cohort of chronic pancreatitis patients did not have a history of acute pancreatitis. And there are other recent reports of that type, for example, from the Mayo and others of, in the literature. And that's what the adult literature reports. Whereas if you look at the pediatric literature, and particularly the stuff that came out of the INSPIRE Pediatric Chronic Pancreatitis Consortium, 90 to 96% of the children with a diagnosis of chronic pancreatitis had a history of an acute attack, and in most cases, acute recurrent pancreatitis. And so I guess that bodes several questions. One is whether age is a risk factor for one type of progression, and importantly, why that might be the case.
Yeah, thanks a lot for that comment. Excellent comment. We looked at the risk factors for progression in the adult population, which was the study cohort of this one. And we could see that the middle age, meaning between 40 and 60, they had the highest risk for progression towards chronic pancreatitis. So age was certainly a risk factor. The older age was most likely decreased risk due to competing risk from death. But I think your point about pediatric patients is very interesting. And I think maybe we should do a version 2 and look at pediatric patients below 18 and see what's happening. We might find a different pattern, and that could be very interesting and fairly easily to do. Thank you.
Great, and we'll go here to my left, please.
Somnath, University of Miami. Thank you, panelists, for such a great talk. My question is towards Amanda. I know Dr. Del Giorno has been really pioneering the work on Tuft cells. Is it known what defines these cells, like gene signature-wise? Is it possible to bring them back? I know that mysteriously they happen to show up during the patent stages, and all of a sudden, they can, because normally they're never found, right? So is it known what can, push them towards more carcinogenesis or pancreatitis, like what you're seeing? Can you just comment on that, please?
If I'm understanding the question correctly, are you asking if there's a known mechanism of how these Tuft cells arise in pancreatitis versus oncogenesis?
Correct.
Okay. So Kathy published a paper actually in Gastro identifying the role of Tuft cells in oncogenesis, where she found that when Tuft cells had a KRAS mutation, they were suppressing, or when there was a KRAS mutation in the pancreas, Tuft cells, they were suppressing or mitigating injury through the secretion of eicosanoid PGD2. And so we're still trying to uncover the role of Tuft cells in pancreatitis, but I think that going in the direction of this IL-25 cytokine can help us understand if that is the route that these Tuft cells are using in the context of pancreatitis to mitigate injury.
Thank you.
To my right, Rich.
Thank you. I'm Richard Waldron from Cedars-Sinai. My question is for Dr. Dahia. I wonder if you wouldn't mind, would you like to restate your thesis of your talk title? Because acinar cells have been proposed to regenerate through acinar ductal metaplasia. So if not, then what are ADMs and where do acinar cells arise?
Okay. So thank you for your question. And so according to me, what we don't know that for what the ADMs are now, because but we prove that the acinar regeneration does not go through ADMs. So it's just a speculation that the ADMs are only a survival mechanism for the acinar cells.
We'll go to our left here and then finish off on the right.
Thank you. Yeah, this question is also for Dr. Dahia. So now with single nucleus RNA sequencing, they've identified different kinds or states of acinar cells, idling and senescent protein synthesis or reg expressing. So do you have an idea of which state the acinar cells that tend to proliferate fall into? And do you think there's a state that tends to go towards metaplasia versus a state that goes towards proliferation?
Okay, so if I'm understanding your question, you are asking that how much work we did we do any work on the single RNA sequencing or not, right?
No, so in single RNA sequencing, they've identified different kinds of acinar cell. Some that are idling, some that make a lot of protein, and then some that express reg proteins. Do you know if one of those is more likely to proliferate than the other?
Yes, but we didn't reach out till there. It's still for this project. It's still the work in progress, and maybe I'll take your thank you for your feedback, and in near future we will work on it, and I'm looking forward to that one also. Thank you for your suggestion.
Thank you.
Please.
Peter Banks in Boston. I want to follow up on Phil's question about diagnosis of chronic pancreatitis. Pancreatic atrophy is not so easy to diagnose radiologically, and different radiologists have different ways to approach it. So I want to know whether you have a common way that one person used to identify the presence of pancreatic atrophy.
Yeah. So pancreatic atrophy in this study was based on radiology, like radiology report. So this was not prospectively reviewed by radiologists. So it is possible that most of the time that they miss some. I would say usually people don't overcall pancreatic atrophy. It's actually getting often missed sometimes. So what we found that if the pancreatic atrophy was found, we have this, it has a higher prediction, but I agree this would be one of the limitations that prospectively we don't have a well-defined criteria for what is pancreatic atrophy. This was only based on finding the word pancreatic atrophy in report from CT scan or MRI.
Yeah, again, I would come back and say that there's so many things that we do in chronic pancreatitis, acute pancreatitis, where there's no agreement, and until you get to a point where you have agreed upon a definition of how you determine that someone has chronic pancreatitis, or rather has pancreatic atrophy, I think you have a problem.
Yes, and I feel like next step would be to do this in a prospective way to see if the model will work very well prospectively. Totally agree.
Great, and we'll go to our final question here for the first half of the session.
Pei Wang from UT Health, San Antonio. So my question is to Amanda. So you showed that the tough cell will appear or transdifferentiate from acinar cell during pancreatitis. My question is, when the pancreatitis dissolve, will those cells go back to acinar cell or will stay there? That's the first. Second is, during chronic pancreatitis, do you see more of those cells come out? Oh, yeah.
Hi. In the context of chronic pancreatitis, I think I'm not 100% sure, but I think that the tough cells can revert back to acinar cell origin. And your other question about chronic pancreatitis. So when we do cerulean treatments, we do see an increased amount of tough cells as we increase the weeks that we treat the mice. So the amount of tough cells are correlated to like the degree of injury. But when there's more, like when they progress into tumor or cancer, the tough cells are no longer present.
Okay, so sorry, quick question. Other than those specific marker, what's the difference between those tough cell versus the ADM cell, like the acinar become ductal-like cell? Thank you.
So the tough cells, they have what we usually stain for are markers like DCLK1 or PAU2F3, which is the transcription factor responsible for tough cell formation. And they really have this distinct structure with these long, deep actin rootlets. And so when you stain for like phalloidin or even with other cell markers, you can just kind of distinguish them with staining.
I had a question for Dr. Olsen. Were they administered any diet questionnaires, and what percentage of their diet came from a fat diet in your patients? High fat. in your patient cohort? Did you administer diet questionnaire to them?
No. This is national health registries. So these are registries that are basically driven by the clinical practice in Denmark.
Okay.
So every time we see a patient in the hospital, when they're discharged, they have a diagnosis code about the certain case they were hospital due to hospitalization. So we don't have this deep granularity of the data, but we have the possibilities because we have some other clinical database to merge databases. And in this direction, we can, for example, have very long follow-up, for example, for mortality and so on, and merge the databases. Yeah.
Okay, thank you. So we move on to our next cohort of speakers. The next speaker is a young investigator, or authored by a young investigator, Stephen Wilhelm, from Washington University in St. Louis. The title of his talk is "A Mouse Model of Salmonella Develops Chronic Pancreatitis Through Protein Misfolding."
Hi, thank you for the opportunity to be here. And today I'd like to present my lab's work characterizing a novel mouse model of chronic pancreatitis. Where's the clicker? This thing? This one. Great, thank you. Sorry. Mounting evidence suggests that mutation-induced protein misfolding may be an important pathway for the development of chronic pancreatitis. Our understanding of this pathway is very limited due to the lack of animal models. CEL modi is a mutant allele associated with chronic pancreatitis in people. It was originally identified as maturity onset diabetes in youth, hence the name, but further evidence suggested the diabetes was secondary to CP. Our lab's previous work had shown that human CEL modi expressed in cell cultures resulted in protein aggregation, ER stress, unfolded protein response, and cell death. We have created a mouse model with the CEL modi mutation and analyzed the pancreatic tissue from ages 1 through 12 months to determine if these mice develop CP. Because this is an autosomal dominant disease, this talk will focus primarily on the comparison of wild type and heterozygous mice, but homozygous mouse data was also collected. First, to see if mouse and human CEL modi are similar, we used HEC293 T cells to express mouse CEL or mouse CEL modi. This confirmed that the mouse CEL modi retains activity, although with reduced secretion. Unlike my lab's previous work with human CEL, mouse CEL was present in noticeable amounts in the detergent insoluble fraction. However, the mouse CEL modi protein is present in much larger amounts, suggesting protein misfolding. To test the hypothesis that the mutation leads to the development of chronic pancreatitis through protein misfolding, we generated a mouse model of CEL modi. This was done through homologous recombination of mutant human CEL exon 11 into mouse CEL exon 11, allowing for expression to be controlled by endogenous elements. We confirmed the presence of the mutant protein in the mouse pancreas by immunoblotting. As expected, the mutant protein is noticeably larger than the wild type protein because the human exon 11 that we added was larger than the mouse exon 11. When harvesting pancreatic samples, we noted the weight of both the mouse and the pancreas. Relative to wild type, body weight did not differ, but pancreas weight was significantly decreased in heterozygous mice, indicating pancreatic atrophy. Analysis of blood serum also showed higher amounts of amylase in the serum of heterozygous mice compared to wild type mice, suggesting pancreatic damage. H&E staining showed that pancreas from wild type mice remained normal from ages 1 through 12 months. However, the pancreas from CEL modi heterozygous mice showed progressive change with age. Examination of larger sections of pancreas show that the pathological changes in the heterozygous mice, most notably fatty change and loss of acinar cells, tend to be focal, with large portions of the pancreas continuing to look healthy. As we can see in the 12-month-old pancreas, the small patches of pathological change can become very large over time. Next, by immunostaining, we confirmed that the macrophages were the predominant cells in the pancreas from the modi heterozygous mice, with some CD3 positive T cells and very few B cells also present in the pancreas of heterozygous animals. It is important to note that the immune cell infiltration happened in the same region of the pancreas that experienced fatty change and acinar cell loss. We next looked at fibrosis with trichrome staining shown in blue. In comparison to the wild type, the Modi heterozygous mice had visibly increased fibrosis, specifically in regions that experienced other pathological changes, and fibrosis was further evidenced by an increase in pancreatic hydroxyproline content in the Modi heterozygous mice. We then looked at lipase and amylase activity to assess pancreatic exocrine function. In general, the Modi heterozygous mice, when compared to the wild type, had decreased activity in both exocrine proteins as the mice progress in age, suggesting reduced exocrine function. We also examined trypsin activity compared to the wild type. And it is noteworthy that ages 3 and 12 months, the heterozygous mice have no change in trypsin activity, and at 6 months, the difference is small with a p-value only equal to 0.044. This data suggests that pathological change is likely not a result of trypsin autoactivation. Collectively, the data suggests that our mutant mouse model develops chronic pancreatitis based on the phenotype of pancreatic atrophy, fatty change, acinar cell loss, inflammation, fibrosis, and reduced exocrine function. We next turn towards beginning to understand the mechanism. We first looked at catalytic activity as a possibility. We transfected HEC293 T cells with plasmids containing the mutant CEL Modi gene, as well as mouse CEL Modi that contained an additional mutation changing serine to alanine at amino acid 214, part of the active site. Lipase activity was measured to confirm that the S214A mutation resulted in catalytic inactivity, and immunoblotting confirmed that mutant mouse CEL was produced, secreted, and formed insoluble aggregates. When we then generated a new mouse line that had the S214A mutation mentioned earlier. Pancreas histology from mice with only the CEL S214A mutation appear normal and healthy, but CEL Modi S214A mouse pancreas continues to show progressive pathology in line with CEL Modi. Therefore, catalytic activity from the mutant CEL was not responsible for the chronic pancreatitis. We then wanted to see if protein misfolding happens in the CEL Modi mice, similar to how it does in cell culture. Through immunostaining, we showed that CEL in wild-type mice is present in punctate staining consistent with zymogen granules throughout the acinar cells. In the CEL Modi heterozygous mice, however, CEL is more densely localized within certain parts of the acinar cells, suggesting that it is aggregating there, likely as a result of protein misfolding. To see if pancreatic expression of CEL Modi caused ER stress and unfolded protein response, UPR, we first used electron microscopy to evaluate ER structure. Compared to wild type, Modi mice showed dilated ER, which is a direct indicator of ER stress. We also measured gene expression through RT-qPCR of 2 major markers for ER stress, BIP and CHOP. In older mice, when we have most clearly seen pathological progression, both BIP and CHOP expression in the CEL Modi heterozygous mice were upregulated, suggesting increased ER stress and UPR. So in summary and conclusion, our CEL Modi mice developed spontaneous chronic pancreatitis through mutation-induced protein misfolding and ER stress-related mechanisms. Our CEL Modi mice will be a valuable preclinical model to further define the protein misfolding pathway for the development of chronic pancreatitis. And finally, I would like to thank the members of both my lab and the lab with which we collaborated, as well as the funding sources listed at the bottom. Thank you for your time, and I'll be happy to answer your questions later.
Yes. Thank you, Stephen. Our next speaker is Dr. Alyssa Downs from the University of Minnesota with her title, Nutritional Risks in Patients Undergoing Total Pancreatectomy Islet Autotransplantation in the Post Consortium.
All right. Hi, good afternoon. As stated, I'm Dr. Alyssa Downs, and I'm proud to present our research entitled Nutritional Risks in Patients Undergoing Total Pancreatectomy and Islet Autotransplant, or TPIAT, in the Post Consortium on behalf of my co-authors and the centers in this study. Here are disclosures. By way of background, I'd like to just point out that most TPIT research currently focuses on quality of life and diabetes outcomes, but there's really been minimal research published on nutritional outcomes. And I think by way of background, as you see from the kind of extensive surgical process of TPIT as depicted in this picture, these end up being vitally important. So on the left diagram, you can see the organs that are removed during TPIT in the gray shaded areas. And then on your right is the post-TPIT anatomy. With that resultant change in anatomy, TPIT is going to increase your risk for nutritional problems. So among those, the resultant complete exocrine pancreatic insufficiency that this produces, or EPI, partial duodenectomy with or without pylorus resection based on the center and the surgeons that are operating, and then the intestinal and biliary reconstruction that occurs. In some single center post-TPIT cohort studies, we've seen increased prevalence of fat-soluble vitamin deficiencies, but currently this has not been reported more widespread. And currently there's no official consensus regarding nutritional monitoring after TPIT. To that aim, POST, or the Prospective Observational Study of TPIT, has developed over time, and their main aims are to determine the best factors for TPIT outcomes regarding pain relief, quality of life, and diabetes remission, as well as to just demonstrate the cost effectiveness of TPIT. And they have extensive kind of preoperative phenotypic monitoring as well as a biorepository. This includes both adult and pediatric recipients and includes 13 collaborating centers across the United States, and it is NIDDK funded. And for more information, you can visit our website. For your interest, I've highlighted the 13 collaborating centers here across the United States, and I've seen a lot of the PIs in this room today, so thank you for contributing your patience. The methods of our study included some extensive kind of baseline pre-TPIT measurements from things like demographics to pancreatitis history, including risk factors such as genetics when it's been assessed, in terms of things like pancreatic enzyme replacement therapy and their vitamin usage, as well as vitamin levels and anthropometrics. Our baseline pre-TPIT is from January 2017 to August of 2021, and then included 6-month and 12-month follow-ups, where again, we assessed enzyme usage, vitamin usage, fat-soluble vitamin levels, as well as anthropometrics. And I've highlighted numbers at each time point. You can see that not all individuals have currently made it to all levels of follow-up yet, as this is sort of a living, ongoing prospective database. For some of our analyses, we did really just include people that had pre and 12-month follow-up. I've included a slide just of our recipient demographics, so you can kind of see the heterogeneity of our study. This included 348 overall individuals, 2/3 of which were adults and approximately 1/3 were children. 37% were male. There we go. 93% were white or Caucasian, and 88% had chronic pancreatitis prior to TPIT. Our adult and children recipients were fairly similar across these categories with a few key differences. Notably, adults had longer duration of pancreatitis, and then children were more likely to have genetic testing completed, to have a positive genetic test, and to more likely have PRSS1 as their etiology. As we looked at both baseline and then follow-up levels of fat-soluble vitamins, you can kind of see that fat-soluble vitamin deficiencies were fairly common pre and post-TPIT, and this is above baseline levels of those with chronic pancreatitis and in the general population. This slide in particular is comparing adults and children at these different time points. A few key differences were that adults were more likely to be vitamin D deficient pre-TPIT, and then at 6 months follow-up had rising levels of vitamin A deficiency and rising levels of similar levels of vitamin D deficiency. By that 1-year follow-up, vitamin A deficiency remained at that tripled level from baseline in adults. Oops, sorry, go back to that. And that remains statistically significantly different from children. As we compared vitamin status to BMI, or status or weight status, we were able to identify that lower vitamin A and E levels are more prevalent in those that had abnormal BMI values. So here, looking at those that were underweight, they had an increased prevalence of all of the vitamin deficiencies, but this was statistically significant for both vitamin A and vitamin E deficiency. As we then assessed vitamin status based on your type of vitamin supplementation, we found that there were decreased rates of vitamin D deficiency at that 1-year follow-up in those that were taking a pancreatic multivitamin. So this is highlighted in the first column in terms of those that were on a pancreatic multivitamin, and seeing that that was statistically significant at that 1-year follow-up. Interestingly, we found that pancreatic multivitamin use was not universal after TPIAT. Children in the pie chart on the right were more likely to be on a pancreatic multivitamin, which is the shaded area of the chart in teal, versus adults. However, adults were more likely to be on a standard multivitamin, which is the purple section of the pie chart on the right, and additional vitamin D, which is sort of the orange or pink section there. We next assessed some anthropometric changes, and we're able to find that normal weight status actually improves after TPIT in both adults and children. So the figure on the left is pre-TPIT values, comparing children and adults with underweight in the orange, normal weight status in the blue, and overweight status in gray. And that is in direct comparison to kind of 1-year follow-up, where we can see that in children and in adults, that normal weight status does improve over time. However, there's a small number of adults that were underweight at baseline, there in the orange, with increased underweight status at that 1-year follow-up. But most notably, most individuals were normal weight status. A few themes in my remaining time. I would just like to highlight home that fat-soluble deficiencies are very common post-TPIT. And we see this tripling in adults by the 6 and 12-month follow-up at 1 and 3, and then tripling in children at that 12-month follow-up up to 1 and 5. Most individuals will reach a normal weight status at follow-up. However, abnormal BMI status, so if you're underweight, you'll have an increased risk of A and E deficiency. And then if you were on a pancreatic multivitamin, you had a decreased risk of D deficiency, and that this pancreatic multivitamin use was not universal, with only 1/3 of adults being on a pancreatic multivitamin and only 2/3 of children. In terms of our conclusions, so we definitely see that vitamin deficiencies are common and increased, and we do think that nutritional monitoring and supplementation of fat-soluble vitamins in the pancreatic multivitamin formulation can be protective against those deficiencies, but they do need to be prescribed. And we can see that TPIT can improve weight status over time, but ongoing nutritional support is needed because an abnormal BMI is going to be more associated with deficiencies. I'd like to acknowledge my core group of researchers that helped me complete this research, but then the PIs from the Post Consortium, and then the Data and Coordinating Center, as well as the NIDDK. Thank you.
The final speaker in this session is another young investigator, Caitlin Castle from the University of Wisconsin. Title of her talk is Impaired Long-Chain Fatty Acid Metabolism Leads to Reduced Secretory Function, ATP Levels, and Pancreatitis in Acinar-Specific CPT2 knockout mice.
Hello, I'm here today to share some new work on a new mouse model, carnitine palmitoyl transferase 2. First, I wanted to start with some background. Pancreatic axonar cells have unusually high energy demands to support high rates of protein synthesis and secretion. So far, few studies have addressed whether axonar cells preferentially utilize fatty acid beta oxidation for energy. So in this study, we aim to understand the consequences of impaired long-chain fatty acid utilization on axonar cell function. As an introduction to CPT2, or carnitine palmitoyl transferase 2, long-chain fatty acids, carbons 13 through 21, require oxidation in the mitochondria to be used as fuel. Fatty acid acyl-CoA synthetase adds the acyl group to the fatty acid in the cytosol. Carnitine palmitoyl transferase 1 on the outer mitochondrial membrane transport those acyl-CoAs into the inner mitochondrial space. Those acyl carnitines are then actively transported by carnitine acyl carnitine translocase and translocated into the inner mitochondrial membrane. There, carnitine transferase 2, CPT2, can remove the carnitine and allow the fatty acid acyl-CoAs to undergo beta oxidation and enter the TCA cycle for fuel. To study the effects of long-chain fatty acid oxidation in the pancreatic acinar cell, we utilize the elastase Cree promoter specific for pancreatic acinar cells in combination with CPT2 floxed mice to create an acinar cell specific CPT2 knockout mouse that is tamoxifen inducible. CPT2 has been knocked out in other tissues. Previous studies have shown that CPT2 knockouts in liver and cardiac tissue require high fat feeding or fasting to see a pronounced phenotype. For our studies, we initially started with 3 diets: a chow diet with 14% fat, a low fat diet with 10% fat, and a high fat diet with 60% fat. All diets were fed for 10 weeks at about 2 months of age. CPT2 acinar cell knockout mice had a significant loss of pancreatic mass following 10 weeks of chow diet. Animals fed low fat or high fat diet had a trending decrease in pancreatic mass, but no change in body weight. CPT2 acinar cell knockout mice developed pronounced acinar cell degeneration and inflammation on all diets. Animals fed a chow diet also had surprisingly fat accumulation. CPT2 acinar cell mice also developed extensive fibrosis on low fat and high fat diets. The phenotype was present in both low fat and high fat diet. The extensive fibrosis was present on the high fat diet. Initial studies to look into mitochondrial health, we measured ATP levels in CPT2 acinar cell pancreas. We found that ATP was significantly reduced in the CPT2 acinar cell knockout mice. Looking at isolated CPT2 acinar cell acini, we found reduced amylase secretion stimulated by CCK and increased basal secretion. We checked amylase and protein lipase levels, and they were similar between CPT2 acinar cell knockout and controls. Next, we wanted to look at the lipid profile of the CPT2 acinar cell knockout pancreas in collaboration with the UW Biotech mass spec core. We developed a lipid profile of the CPT2 acinar cell pancreas. We found that total triglycerides, acylcarnitines, and fatty acids were significantly elevated in the CPT2 acinar cell pancreas. Looking at acylcarnitines, we saw that 16.0, 18.1, 21, and 22 were significantly elevated in the CPT2 acinar cell pancreas. Although total fatty acids were increased, we did not see a significant difference in individual fatty acids in CPT2 acinar knockout pancreas. In summary, the CPT2 knockout mouse, specifically in the Acinar cells, show that Acinar cells are uniquely sensitive to loss of CPT2, as evidenced by the pronounced histopathological profile I've shown you, and especially in the animals that were fed a chow diet. Long-chain fatty acid metabolism seems to be uniquely impacted in the pancreatic acinar cell, as evidenced by our model with the loss of CPT2 and a significant pancreatitis phenotype. In addition to the histological pancreatitis phenotype I've showed you, we also saw reduced ATP levels, reduced stimulated amylase secretion, and increased basal secretion in isolated acini, and accumulation of long-chain acylcarnitines and fatty acids in the pancreas. We propose that this accumulation of the long-chain acylcarnitines and fatty acids contributes to dysregulated lipid metabolism, potentially mitochondrial dysfunction, and the pancreatitis phenotype we see in these animals. Thank you.
The second half of the session is open for questions. Dr. Singh.
Vijay Singh from Scottsdale. That was an excellent talk, Caitlin. There is a common phenotype we are observing in these mice that develop chronic pancreatitis, whether it is because of lipid metabolism or an unfolded protein response or a trypsin mutant, and that is fatty replacement. That the exocrine goes down, adipose goes up. So this yin-yang effect is fairly universal and doesn't seem to be specific for just a lipid metabolizing system. So I have a couple of questions and a couple of suggestions. The question is that how can you associate the lipid changes you note with the fatty acid increase with the specific mutation that you have induced and differentiate it from, let's say, the carboxyl lipase mutations that were talked about earlier, or the trypsin mutations that you talked about earlier, since all of them have fatty replacement?
Thank you for your question. I think that is an excellent question. In this model, it is a acinar cell specific CPT2 knockout. And so we're able to assess the effect of that specific deletion. But I think we would need further studies studying the other enzymes important in that pathway to figure out how CPT2 is interacting with all those other enzymes responsible for lipid metabolism.
Okay, great. So there is perhaps some commonality to the phenotype we observe, and this has been my suggestion in the past and now also, that there's probably a de-differentiation process taking place at the same time. So you're losing exocrine mass, you're increasing adipose mass. Somewhere in the middle, you'll catch this. And you'll see, if you start looking at cell death markers specifically, you'll probably see in the middle somewhere increase in cell death in acinar cells as the adipose goes up. So that would be a suggestion if we can, especially integrate it with the other people who, or other groups that observe this phenotype. The second suggestion I would have is when you see this decrease in acinar secretion, which is stimulated, and increase in basal, this, which we have experienced in the past, is most likely from acinar injury when you are shaking your acinar cells and collagenase with adipocytes. So that's the adipose releasing fatty acids killing your acinar cells, most likely. Have some orlistat in the medium. And you'll block lipolysis, your acinar viability will go up, responsiveness will go up.
Hi, a quick question about the cell MODY mice. What is your wild type control in these experiments?
The wild type we used for the experiments that you just saw is just standard C57 mice. We did also produce another wild type control with a 16R VNTR repeat to replicate on the human version of CEL without the MODY mutation. That didn't have any signs of pancreatitis, so we just didn't include it in this presentation for simplicity, but we have been collecting data on that.
I see. And in the precipitates, do you see the wild type protein too, or only a mutant precipitates? You're showing like these intercellular inclusions.
For the insoluble CEL
Yes.
protein.
Yeah. Since
in the
it's a heterozygous mouse, so what happens to the wild type protein?
Right. As I showed in cell culture, we've been able to see both mouse CEL and the mouse CEL modi are aggregating and forming visible
Okay.
insoluble protein. In the mouse itself, we're not able to see that in either. That may be due to a protein extraction inefficiency. We're confident it's not due to an antibody issue because it's not binding to the VNTR region. It's binding to a common region between both CEL and CEL modi. But we're still figuring that out.
Thank you.
If there's no other questions, then Dr. Osipov and I would like to thank all you speakers for outstanding talk and for staying on time so that we concluded the session right on time at 3:50. Thank you all.